Welcome. Today we are discussing how an independent physician practice can provide a cost-effective patient care. Today we're here with Larry Jones, Executive Director of IPN, and April Peterson, Director of Network Development. Larry?
Thank you, April. This is probably the most important topic that we could talk about when it comes to the performance and the cost containment and cost management of patient care with our independent physicians. There are maybe 5 or 6 things that physicians and their staff need to be engaged in on a regular basis. Number one is obviously admissions, where your highest inpatient cost and dollars are. In the Orlando market, inpatient cost represents about 65% of the total cost of care. The other piece is pharmacy management. Drug management with some of these payers is approaching 25% of the total cost of healthcare today. But admissions and readmissions are at the focal point of managing these patients. And then it follows with ER visits. Our physicians need to have a program to where if they're closed, their patients know exactly what to do. Whether it's having the information on an urgent care center that's around the corner from their practice or within a 5-mile radius of their practice, or call them and get with their answering service or their after hours team before they go to the ER or before they go and just try and admit themselves to a hospital for whatever reason. 85% of all care in America can be delivered in an outpatient arena. It's estimated that less than 15% of all care in America needs to be provided in an acute care inpatient environment. So with that in hand, what do our independent physicians really need to do to be able to maintain this? First of all, primary care doctors don't go to the hospital anymore. They don't make rounds. So they need to have an assigned hospitalist that they're comfortable with to make sure that when their patients do go to the hospital, whether it's the ER or whether they're admitted in a 23-hour stay or a 2 or 3 day admission, that they have someone that knows who their primary care is, has the background of the patient, and can get that information quickly and manage that patient in a more effective and a more cost-effective way.
Well, you also mentioned, too, the number of consults that an independent hospitalist does versus a hospital-owned hospitalist. What was that
That's
again?
a good point. We've seen studies to where hospital-owned hospitalists provide 5 to 6 consults per patient on average. Independent hospitalists, 1 to 2 consults on average. And that is a tremendous amount of dollars that are being captured, even though they're considered inpatient. It's specialist referrals, it's imaging, it's rehab, it's all the things that can be done in an outpatient setting at a fifth of the cost once the patient's discharged from the hospital.
And typically much higher patient satisfaction.
Yep. Absolutely. No question about it. Patient satisfaction. People don't want to go to the hospital. They'd rather go to their doctor, have outpatient treatment, and go home and sleep in their own bed at night. And that's what cost containment and cost management is. The other one is ER visits. Our doctors need to educate through their staff, our patients, that you don't use the ER for a bad cold on Saturday night. You go to an urgent care center. You go to a minute clinic, and you can get a Z-Pak or azithromycin or whatever you need, versus going and running up a $3,500 hospital bill at an ER. The difference between an urgent care center and an ER cost is $150 versus an average of over $3,200 per visit. Tremendous costs. And then the last thing is chronic care management. Our patients that we know, the diabetes, the cardiovascular, the COPDs, the CHFs, these chronic conditions that are pretty routine and a lot of patients fall into these categories. 35% of patients in America have diabetes, but yet diabetes can be managed to where it never creates an insulin drop or a problem to where the patient needs to go to the ER or be admitted. And again, things like telemedicine, things like after hours call service and triage, and all these things that patients have access to versus going to the ER, going to the hospital. And then the last one is really access to the physician in a timely manner. Physicians need to plan in their daily schedule an hour during their day for an emergency. And very few physicians do that because they're trying to see 30 to 40 patients a day to maximize their patient load as well as revenue for their practice. And I think when you look at all these different types of cost containment, cost management process, it's all about communication. It's all about education with the patient. And the staff is even more important sometimes than the physician in managing and containing costs for these patients.
That transition of care, yes, keeping them in that independent environment and making sure they're getting actually the most appropriate care for that situation.
Yeah. And then the last thing that I want to just touch on briefly is specialist referrals. In value-based care in patient-centered medical home type environment, primary care physicians need to learn to do more for their patients than just refer them out to a specialist. So many things can be done in the primary care practice today that wasn't done many, many years ago. The tools, the technology, and everything that patients need, many of that can be done with a primary care physician.
But also primary care physicians need to monitor who they're sending to their patients to for specialist referrals, because we have seen on the shared savings and surplus side many times where one particular cardiologist is extremely high utilization where a whole bucket of other ones are not. And so it's a challenge. It's helping physicians identify who is going to actually complement that primary care physician's practice from a specialist referral.
April, you hit on a real important point. It is challenging.
Close the circle of care.
But it's also important that physicians break the habit of just referring to their buddies and not looking at the cost containment and the cost and quality of care and the outcomes of their patients. And when we compare many of the specialties within IPN to IPN physicians versus non-IPN physicians, we found as much as a 20 to 30% cost difference lower in the IPN side than in the non-IPN physician side. So as we provide direction and analysis to our physicians in these value-based and these MA contracts, we give them that data so that they can change their behavior if need be, or educate their specialist as to what they expect. Because today, the primary care is the gatekeeper, and that word is not used, but primary care is king.
And that fee-for-service transition that's turned into fee-for-performance, that's centered all around this value-based arena, it puts the PCP in charge of all the dollars, of the care, the satisfaction, everything. So it's imperative that primary care get more involved in what's happening with that patient outside the office.
And in closing, April, you led right into the most key point. The days of physicians opening their door, seeing patients, closing their door, and going home is over. Coordination of care, driving that circle of care with their patients is most important in becoming a high-performing in-demand practice. Thank you.